This year, beginning of this new year, we're focusing on a theme of I See a New City. We want to explore in more depth what city transformation really can look like. And we're excited over the course of this year that we've got lots of cross-sector leaders from the NHS. We've got academics, pioneers, social enterprise leaders. They'll all be sharing with us. And delighted to have Kit Connick, the Chief Officer for Strategy and Partnerships from Cambridge and Peterborough ICS. We've asked Kit to come and speak to us today about how churches can collaborate with civic and health organisations to multiply the impact in transforming our communities. So we'll interview Kit for half our time, and then we'll throw it out to questions for you all to have the opportunity to say something or to ask Kit a question. Obviously, post-pandemic, we have seen the church do an awful lot in our communities, whether it's around food banks and food provision, whether it's about the warm welcome hubs that are currently running across our communities, or whether I was speaking to David Grant from Basingstoke just as the call started about his project supporting homelessness in Basingstoke. So the church is opening its doors in all sorts of ways to support people in the community. And yeah, we want to just explore the way that we perhaps connect with our health service. So Kit, welcome. Do you want to just introduce yourself first of all, what your job actually means, and then perhaps start us off with a definition about ICSs and ICBs and what that means?
Sure. So thank you for having me, first of all. Hopefully you can hear me clearly. I'm in a hotel in Cambridge, so it's all very posh behind me, but I'm trying to not get distracted by people having fun and drinking in the daytime. Not judging, it's just that Christmas thing hangover. As Mark has kindly introduced me, I'm Kit Connick, and I am the Chief Officer for Strategy and Partnerships. And I'll just try and explain a little bit about what that is and where I started in my NHS career. So I've worked in the NHS for over 20 years in provider roles in mental health trusts, in community organisations, and also in back office functions. So know the NHS locally within our system well in Cambridgeshire and Peterborough. My role within the integrated care system is in the ICB, which is the Integrated Care Board, which is the lean organisation that essentially oversees and manages the delivery of care for health. And I've got accountability, as you'd suggest, for strategy, so the integrated care strategy, and the NHS responds to that through the Joint Forward Plan, which is the 5-year plan for all the health organisations, how we respond to that. I've also got accountability for communications engagement, for partnerships, which is why I'm talking with you here today, about how we reach out, how we listen. And I think listening is a really important part of collaborating, and how we work with our communities in its broader sense. So the people we serve, the population, and also our voluntary sector and faith partners. And then alongside that, accountability for infrastructure, estates and green. So quite a broad portfolio, but essentially what they come together is to really support the integration and how we want to work together with colleagues like yourselves and others across our health system.
So you're really a key leader and the person to speak to from the way you've described your role. ICS is a new term that's come about. I believe there's about 42 of them that cover England, and they represent around about a county size, which is what you're dealing with in Cambridge and Peterborough. But they also have different tiers that they operate at. So they operate at lower levels as well. Do you want to just explain how your role relates to those different tiers? And I guess you must have an awful lot of people that you are part of your team that you connect with those different tiers.
So I think if I start about how ICSs and integrated care systems arose. So prior to ICBs, integrated care systems, there were CCGs, so clinical commissioning groups, and there were 195 clinical commissioning groups. And I think we all recognise that essentially they outgrew their time. And so in 2022, integrated care systems were born. You're right, Mark, there were 42 across the whole country. It's mandated mandated, it's not optional. And the purpose of integrated care systems is to essentially bring all those three words to life, really, by bringing together multiple organisations across geographies. So our geography is Cambridgeshire and Peterborough, covers about 1 million population. ICSs can range from between about 500,000 up to about 3 million. So we're kind of fairly on the small side. We're fortunate in our area that we are coterminous, so our boundaries match that with the local authority, but internally those boundaries are slightly different when you look at our places and some of those district councils. So within our system, we, as you're right, there's tierings around that, and every integrated care system is built upon the same kind of principle and methodology, but it's a different structure, and it all vary depending on the system itself. So in Cambridgeshire and Peterborough, we've split into a north and south. It's not a neat line, but it's roughly halfway up the A14, if anyone knows our patch. And it's about 500,000 in the south and slightly more in the north. There's 49 GP practices within the north and 13 primary care networks, and in the south 39 GP practices and 9 primary care networks in the south. And then you've got all your health organisations. So you've got a mental health trust, you've got acute trusts, you've got community trusts, you've got 2 upper tier local authorities, you've got 5 district councils, you've got the East of England ambulance services. I mentioned the 89 GP practices and 175 pharmacies. And then there's all the parish councils, there's our voluntary sector organisations. So it is a very large infrastructure, and you can imagine the complexity around that. And what we're not trying to do with an integrated care system is take over or manage or control the sovereignty of those bodies. Each organisation remains a sovereign organisation. But in coming together, what we have is a shared intent, a shared vision, and a shared desire to really help and serve the population. Now, the difference, what people do get confused, understandably, between the difference between an ICS and an ICB. So the integrated care system is all of those organisations have come together to form that system, that sense of partnership, of coming together with a shared aim and shared purpose. The Integrated Care Board is the organisation I work for, and that's the statutory body that's taken over the responsibility of the CCG and also additional responsibilities delegated to it from NHS England. And so in terms of my remit, when I talk about strategy, we have a requirement, a regulatory requirement to oversee and manage a significant budget for health and to coordinate health partners, but they act as independent autonomous bodies and organisations within that. But the Integrated Care Partnership is where we come together as a collection of health, care, police and voluntary sector and faith organisations to really think about how we want to work together to think about the longer term aspirations and aims for health and care for our population. Hope that helps a little bit. I know it's complex.
Yeah, it is. Just tell us a bit more about district councils, because I think for most of us, we think about those as local authorities,
Yes.
Smaller units. What's their role in health?
Okay, so if I talk about Cambridge and Peterborough, there's 3 tiers. So there's 2 upper tier local authorities. There's Cambridgeshire County Council and there's Peterborough City Council. So that's a unitary authority and a county. There's also the combined authority, which we have, which covers the whole of that area. And then there's 5 district councils. And this is where whilst we have the geography of Cambridge and Peterborough maps perfectly and beautifully around the outside, apart from a couple of areas around Royston and in North Cambs. Internally, you've got very different geographies for those district councils. But roughly, if you looked at our South Place, you'll find Cambridge City, South Cambs and East Cambs District Council mapped to that geography approximately. And in the north, you'll find that it's Huntingdon, Peterborough, and then Fenton District Council mapped to there as well. So whilst the internal geographies don't perfectly mirror, what we're really conscious of is how we want to think about that relationship that our places that we think about in health have with our district councils and also with the upper tier at the local. So thinking system, place, and then that hyper local level, which many of you on this call will work at, is with those really local communities, integrated neighbourhoods, particular towns, villages, and once you get to a city status, maybe even in streets.
So forgive me, Kit, I haven't quite got what a district council is actually responsible for in terms of health. Do they have any responsibilities,
No.
or is it more right?
So health is accountable for discharging all the health responsibilities.
Yeah,
District councils will be accountable for planning and housing within the local area, things about looking at maybe getting your bins emptied, all the support you have in terms of to live well in an area, but they have responsibility for wider determinants of health. So of course, what we recognise now, you can't live in good health, whether that's physical or mental health, without having employment, without having purpose, without having access to work, access to transport. And so we recognise now that actually it isn't as clear cut as there's health services and that there's district council services or upper tier. We recognise that as organisations, we have direct accountabilities and requirements that we are need to discharge, or duties. But there's so much overlap between physical health, mental health, and the homes we live in and the lives we live. And so that's really important in terms of how we discharge those duties together. And I've just seen that comment about health and wellbeing board. Shall I pick that up, Mark?
yeah. Thanks, Kit.
Okay. So within health and wellbeing boards, within our system, there used to be 2 health and wellbeing boards, and the reason for that is, as I mentioned, there's 2 upper tier local authorities, the Peterborough City Council and the Cambridgeshire. When we came together 2 years ago, there was an agreement that actually to have 2 health and wellbeing boards is somewhat divisive and wasn't actually really supporting the overall system aims and aspirations, and was inefficient, frankly. And so the 2 local authorities came together to agree to have a single health and wellbeing board. And the health and wellbeing board's accountabilities are, as you would suggest, to think about the long-term 5, 10, 15, 20-year health and wellbeing needs of a population. Now, even though that doesn't sit within a health remit, the local authority work closely with the health colleagues and have health scrutiny committee and health and wellbeing boards to think about how they hold health to account for delivering things that are really going to impact on the population. And we've also have as the integrated care partnership, which, as I've said, is where we all come together as a group of organisations with senior leaders, chief execs, chairs to meet on a bi-monthly basis. And the next meeting is next Friday, and they're held in public. And what we have done is align the Health and Wellbeing Board to the Integrated Care Partnership. So again, what we've done is condense decision making and oversight of expectation and strategy and intent across our whole population into a single place. And the intent around that is to stop duplication. It's to be clear about what our shared purpose is, to make sure we hold ourselves and one another to account, and that we're accountable to the population, so that when we talk about strategy and aspiration, and then we look at action plans, it's very clear that we aren't at odds with one another or duplicating, or somehow things get missed in that.
Right. And so the ICP, the Integrated Care Partnership, also has a place for the VCFSE, Voluntary Community Faith Social Enterprise organizations. Is that right? Can you tell me how that works?
Yes, so we have on our Integrated Care Partnership membership a seat at the table, and that is held at the moment by Julie Farrow, who is the chair of Hunts Forum, and we also have membership from our VCFSE colleagues on our board subcommittees as well. And so what we've done there in doing so is trying to really demonstrate there's an equal seat and an equal voice at the table, because when I took on this role, the feedback I had was that it often the engagement with health, and I talk about the organisation I used to work with as well, the one I do now, it felt somehow second best, that the people weren't at the table making the decisions. So what we've done is make sure that that is very visible now, and that our colleagues in the volunteer and faith sector have representation at those corporate meetings. Moving beyond that, though, what we've also recognised is that it's not just about having a seat at the table, it's been able to influence through local decision making. And so there's also representation at the place boards we've talked about, so that there's an understanding of what matters to that local population, not just at the system level. And then also investing in infrastructure and support. And I think that from my perspective, there's a understanding that whilst it might be convenient for us to talk about the VCFSE as a homogenous thing, it isn't. It's a number of organisations that may be national, regional, local, hyperlocal, and that we need to understand the complexity and the challenges around that. And so there's quite a lot of work happening at the moment about how we in health, that's led by myself and Andrew who's on the call, along with colleagues in district council and the upper tier, about how we really support the infrastructure. And that may be about funding. It's around volunteering, about being better support to engage with volunteers. And it's also around supporting around sustainability of those organisations and acknowledging the contribution they make to the wider population.
Great. There's lots to explore there, but I want to just ask about the wider objectives of the ICS. One of the things that I think we really share a mission in between the church as part of the faith sector and the ICS is this aim to reduce health inequalities. Maybe you could just explain what you understand by that from the ICS side to start us off.
So I think health inequalities is a very broad term for things that we can all understand directly and may have experience of either personally or through our families. And within that could be things about mental health, it could be physical health, it could be access, it could be from long-term conditions that people have. So what we have recognised across Cambridgeshire and Peterborough is that if you only look at a system level, you see high-level population data, and data doesn't tell the story about what's happening in people's lives. So what we've really done is to invest and understand in what that data tells about particular communities and about some of the health inequalities that affect those communities. So, for example, across Cambridgeshire, what we have is a very diverse population. We have pockets of deprivation in Cambridge that is sometimes hidden by some of the very visible wealth and affluence. We've also got within our rural communities extreme deprivation, and then within Peterborough, you've got a very diverse community as well. And one of the areas that you may have heard about will be about the Core 20+5, which is an NHS and a kind of national initiative. And what that essentially sets out to do is to focus on the 20% of the most deprived population in the 5 main areas that we know people are affected by. So that's things like asthma, diabetes, epilepsy, oral health, so dentistry, and mental health. And then we look at the plus bit is about those specific cohorts of people who are also additionally disadvantaged. So there may be ethnic minorities, people with physical disability, or people with long-term conditions in mental health. And so really, in terms of those health inequalities, I think there's 3 elements. There's firstly, knowing who those people are, knowing where they are, and knowing some of the challenges that affect them as individuals and as communities. The second is about having a focused and targeted approach to how we're going to support those individuals and those communities to address some of the challenges they're experiencing. And the third is about who we collaborate with and what are we going to collaborate on. So how do we work together with yourselves and other partners to really tackle those? So if I took, for example, somebody who has a long-term mental health condition that they live with, we know that people who have mental health challenges may find it hard to stay in work. They may find it hard to ask for support, whether that's for housing benefits, for social benefits, to access some of their support networks. And so what that does is reinforce some of their mental health challenges and can lead to social isolation. So we know that actually you can't fix that problem just through giving people either drugs or through talking therapy. They need support to help them live the best life they can with the condition they have, and to understand how to manage their condition. And so that involves people through adult social care, perhaps. It could be people from the voluntary sector. It could be about social prescribers. It could be about giving people to support to get back into work and to remain in work. And so what you can see through that example, actually, we need the whole of our integrated care system partners to really understand the needs of that individual, that community, and to work together to address those needs rather than saying, well, actually, you've had one thing, go away and find the other thing yourself. We've got to really wrap care around these particular individuals or communities to really support them to achieve their potential.
Thanks, Kit. And I guess for many of us who work at grassroots level, we do see a growing gap, a growing number of people suffering, health inequalities. I mean, do you have any good news or aspirations that actually we could reverse this trend, that actually we could see a continual reduction in health inequality, or are we just, losing the battle, so to speak?
Mm. So I think that we need to be realistic about the challenges. So we also look at that data, and it concerns us equally in terms of the challenges that we recognise that the comorbidity of people's physical and health and mental health, and then also the impact it has on their general well-being and their life outcomes, frankly. I think we can address it. Uh, we need to recognise it's not a quick fix, because these are not things that have arisen quickly and overnight. We know that COVID has exacerbated the challenge for many, particularly around some of the mental health and isolation and loneliness. And then, of course, the cost of living crisis that is ongoing. That has created further challenges. So I think we've got to recognise that this is not something that we're going to say in a year's time it will all be magically resolved. But we do have to understand where and how we're going to target the problem, where we're going to make the most impact, and how we're going to work together to address that. And then, really importantly for us, about and what does the data tell us? How will we know we're making a difference? How will we hear from our communities that some things that we're doing aren't making that impact, and how, where they are, we continue to invest in that? So that is where, in terms of our data and understanding what those health outcomes are looking like for our population in the next 5, 10, 15 years, really starting to look at how we can understand for people the difference we're making through the services we're delivering. And when it's not working, to say, actually, we've got to change it and shift it.
Yeah, right. In terms of your perspective on our community across Cambridge and Peterborough, I mean, what would you say are the priority needs in the community? And then how does that perhaps relate to some of the top priorities you've got as an ICS in terms of your strategy as an organisation?
Mm. So I think that we've got to be we could talk about, in terms of some of the general challenges I've mentioned around mental health conditions, around obesity, around asthma, those kind of health issues. I think realistically, each community is going to have different needs. So I wouldn't want to be overgeneralized and say, well, there's 5 top things that are going to really impact over the course, that we could list off some of the major health issues. I think we've got to recognise we've got an ageing population.
Yeah.
That is a real challenge for us, and how we help that ageing population to stay well, and importantly, stay at home where possible to avoid hospital admission. I think we have a ongoing across the country mental health, I don't want to call it a crisis, but a mental health challenge, and how we can support people to either avoid that becoming a crisis for them, early intervention and support, and to avoid social isolation. I think we'd all recognise in the roles we do around some of the challenges around children and young people and their mental well-being, and then again with the cost of living, about that sense of ambition and helping people to support their personal potential and ambition. So in terms of how people and how you and others on this call can support that, I think it's about knowing your communities, about knowing at that hyper level what they need, and then being able to influence about that need with health colleagues, with social care colleagues and local authority colleagues, about how we can access that and how we support those communities to thrive, as opposed to trying to fix people. Because I think the recognition is that we can't fix everything, but what we can do is prevent. There's something about dealing with the problems we have today, but also preventing the problems arising in the future.
Yeah, yeah. Thank you. Churches are, I mean, we estimate that there's 600 churches across Cambridgeshire and Peterborough, which is a phenomenal asset in the community in terms of buildings, in terms of volunteers, many of them very, very skilled, and in terms of, real concern for people that, are in the community, not just the people that go to the church on a Sunday. I think one of the challenges of churches is that whilst they're doing a lot, actually, there are challenges that they face, perhaps barriers that are perceived to their relevance and their capacity to be an effective partner in their communities. And I think one of the opportunities we saw in coming together with you today, Kit, was to maybe kind of just share some ideas about language and even faith literacy. Have you got any advice for us as church leaders about how we, sort of address the barriers perhaps to collaboration around faith literacy, or the other side, actually, civic and health literacy?
So and please take this the way it's intended. I think that the health is complex system and it's hard to navigate. And I'd say the same about the faith system as well. So I think there's something about, don't expect that we in health or colleagues in local authority know who and where and how to access the right person, the right point at the right time. And like yourselves, we are have multiple demands on our time, and so whether wrongly or rightly, people give up sooner perhaps than they should do, in terms of they may have tried and knocked on a few doors, not got quite the right door, and think, well, I'll give up. So I think there's more that we can do together. So I don't think it's your job or our job on our own. There's something about how do we keep having these conversations so that, depending on where you are in your particular geography, who the right people are to make contact with. So you knock on the right door the first time, and vice versa for us. I think there's something about language, certainly, and it's taken probably best part of 2 years for us from health context to stop talking about patients and talk about population. It's well ingrained that we think about people as patients, and they aren't, not always. And actually, they're people first and foremost, and patients second. So I'm sure that many of you might talk about your parishioners or about your communities. There's something about our common language. I do think that there is piece of work that we in the ICS need to do about really promoting the role of faith organisations. So we are au fait certainly in health organisations about the VCSE. I think the VCFSE is a less common used terminology, and we need to commit to talking about faith groups and how they can support and are an untapped asset, 'cause I think it is. But also, I think there's something about your hyperlocal option. So do you know who your local integrated neighbourhood managers are? Do you know who your local social prescribers are? Do you know who those key people are within the health and care infrastructure? And is that reciprocated? So could you pick up a phone and say, it's, I don't know, Mark from X church, and I've got somebody who needs support and access. Can we make that referral? There is something about that very personal connection. And I can see something put now about that Hey, how are you link, in terms of how do we make those connections. And that Hey website is absolutely brilliant in terms of mapping some of the local geography.
Just tell us about integrated neighbourhood managers. What is their job, and why would they want to connect with church leaders or a network of churches?
Yep. So the integrated neighbourhoods are as I talked about, the system level, and then the two place partnerships underneath there, there's the integrated neighbourhoods. The integrated neighbourhoods manager's role is to coordinate all those various key people in the public sector organisations who might have a vested interest and or role or remit in supporting the local population. So it could be GPs, they could be voluntary sector organisation individuals, they might have links with the social prescribers, local leaders. They are absolutely critical, and they will really know that patch. And what they'll also have access to, which I think is critical for yourself and others on the call, is the key data. So they will have access to the kind of general health data and what the projected population growth is for that area, what some of the challenges are, the housing growth, and what some of the opportunities are about how we know who are high impact users. So who are the people who we know really frequently use services, and identify those people and knowing who and how to connect them. So they are absolutely critical in terms of contacts, and they know their communities really well, and they're trusted, just as you are in your roles. They're trusted people, but probably for a different cohort of the population. And I think from our point of view, where Andrea and I are working with our integrated neighbourhood manager to say, actually, there's faith leaders who will have access to a population who may not trust them in turn.
Yeah.
So there is something about how we open up our networks and help to build those bridges between the communities we support and serve, and seeing where there's overlap and where there might be some gaps.
Yeah. One of the things that Gather Movement has been hearing from civic leaders and health leaders around the country is that in order to engage with churches, it's really helpful if churches can come together with one organisation, one phone number, one website, so that there can be a kind of collective conversation rather than trying to speak to 600 churches individually. It's been absolutely fantastic working with you, Kit, over the last year, and your colleague Andrea, who's on the call today as well. And you've been amazingly responsive with us in terms of helping us with conversations about how we move forward with church network across Cambridge and Peterborough. I know you've both come out and seen gatherings of church leaders in local authorities in Fenland and in Cambridge. And you've also worked with us as we've brought those representative leaders, church leaders from the 6 local authorities around a table with yourself and also with the mayor, the elected mayor there, Nick Johnson. I just wondered what about your comments, because not everybody will have seen that's on the call. But from what you've seen of that, would you want to make any comments about whether that's a good idea, whether other areas should be thinking about doing likewise, or maybe things that we need to think about trying to do that?
Yeah. So from my point of view, I think it's been fantastic. I've learned a huge amount. I think that when you get in a room and have conversations and make the network, and you know the people and you shake their hand, you have a cup of tea, you get to know someone so much better. So there's something about coming together and coming together regularly. I think that if it is feasible to get a single point of contact, fantastic. Recognise that's really challenging. So perhaps some of the opportunity, maybe not a single point of contact, but thinking, where are your communities? How might you think about grouping your networks in a way that's frankly more manageable for the NHS or local authority to access? It may not be you can do a whole geography, but there could be clusters. I think the other thing I've recognised being in that space is just the desire and the will to connect, and some of the frustrations I've heard that actually it's really hard to sometimes get access to the NHS, and it is about people and building those relationships and knowing that when you call that person, they'll pick up the phone, they'll respond. So it is about investing for that long term. We are very willing to continue to do that, and I think that I'd say if anyone hasn't had those connections with their local organisation, then the first point of contact might be with somebody like myself. If you're not in Cambridge and Peterborough, it could be somebody who has responsibility for the voluntary sector organisations, or if you're unsure, then maybe just drop a contact to the engagement or email address in the comms department in the integrated care system that you work in, because they will be able to signpost you to the right place. I think my final thought about it was this is challenging, and we all work in challenging and busy roles, and so we've got to recognise we're taking baby steps and we're making a difference, maybe not as fast as we want to do so, but we are making progress. And therefore there is about acknowledging that whilst there's frustrations, we're all trying to do our best in difficult circumstances with too much work and not enough people, and just staying with it. So recognising that, yes, it'll be frustrating at times, but stay with it and recognise that actually we are committing to working with you.
Wonderful. Thank you, everybody. We're drawing to the close of our time, but I just want to thank you so much, Kit. I guess part of the challenge of this event is to think again about the church needing to take more responsibility for the well-being of the city and the places that it is in. And we've posed some new opportunities by working together that the church has to make a greater impact. And it's been absolutely fascinating to hear Kit's advice and guidance on that. Clearly, there's some way to go, and I think we need to recognise that there's no one organisation, no one church, no one health organisation that can solve all the problems in our community. It has to be a cross-sector collaboration, and this is, I'm sure, an important step on that journey for many of us as leaders. So I want to thank Kit again, and Andrea as well, who I know was on the call, her colleague.